Morning to all of you. My thanks to KMCH Executive Director Dr. Arun Palanisamy, and a special thanks to Dr. Lawrence, who has invited me to give this lecture. As the Executive Director was telling, as the age of the patient increases, the longevity has also increased in our country. What happens is, previously we used to think if a person lives longer, he is prone to get cancer. Today, if a person lives longer without cancer, what he is going to get is cardiac failure. Cardiac failure is going to be the disease that is evolving into a very big scale. One of the papers say the incidence of cardiac failure in the age group below 60 years is only 1%, whereas in the age group above 70 years, where majority of the people go through now, is 10%. So we should know how best to manage the cardiac failure. The common garden variety of cardiac failure is what is called the HFrEF, heart failure with reduced ejection fraction. Most of the people sitting here are cardiologists, trainees and physicians who know that today's dictum is when a patient gets discharged from the hospital to have a checklist whether we have instituted all the 4 pillars of treatment of cardiac failure. What are the 4 pillars? SGLT2 inhibitors, beta blockers, ARNI and MRA, mineralocorticoid receptor antagonists. So these are very good when the patient has got a classical variety of heart failure with reduced ejection fraction. There are many people who get admitted with symptoms of cardiac failure, but what they have is a normal ejection fraction in the ER. When you check the echocardiogram, they have a normal ejection fraction, and this goes under the name of heart failure with preserved ejection fraction. So, when the ejection fraction is reduced, to less than 40%, do you have a pointer? When it is reduced to less than 40%, we call it as HFrEF, and when it is above 50%, we call it as heart failure with preserved ejection fraction. Can we get these things? See, our fundamental book Hutchison used to say, what the mind does not know, the eye does not see. So previously also we were getting cases, but the mind did not know that there could be an entity called cardiac failure with preserved ejection fraction. Today we get to see a lot of patients with preserved ejection fraction. Unfortunately, till today there are no drugs available directly. Only recently SGLT2 receptor blockers have been found to be useful in the management. So all that we do is, they have a preserved ejection fraction, but we go and treat that comorbid condition. So we know the treatment for HFrEF, that is heart failure with reduced ejection fraction, and for HFpEF, we know we have only SGLT2 inhibitors. Now in between, we have what is called a 41 to 49% heart failure with mildly reduced ejection fraction, and this is also common with people who have come with heart failure with reduced ejection fraction, whom you have treated and they have improved ejection fraction. So this category is both mid-range ejection fraction if you are going to find it for the first time, or it is improved ejection fraction if you have treated a reduced ejection fraction and he has improved to between 41 to 49%. What is the implication of treatment of these people? See, when you take a SGLT2 inhibitors, it is useful in all ranges. Now, are there other drugs like ARNI which is useful? That's what we are going to see today. This is the Indian registry, the CSA Kerala registry, which clearly shows, if you look at the upper one, the black dotted one is no guideline guided treatment. Therefore, the mortality is highest. When the person with HFrEF has got what has been given in the guidelines, if you have continued the guideline recommended treatment, the mortality comes down to the lowest, the last one. So this is when you do not follow that. So before the quadruple therapy, SGLT2 came, we had triple therapy, that is ARNI, beta blocker and MRA, and with the triple therapy itself, we were having very good improvement. So what is important is, you should have a checklist when the patient goes out to see that every recommendation is being followed. So whether it is a triple therapy or quadruple therapy, once we start everything, the mortality rate definitely comes down. Now, if you look at these things, in patients with LVEF more than 40%, regardless of whether he has had type 2 diabetes mellitus or not, the paradigm HF trial has very clearly shown that there is an that the reduction of mortality by about 13%. Whereas if you use SGLT2, there is a reduction in mortality of about 21%. So what is important is, even in patients who have LVEF more than 40%, both SGLT2 and glyphosins, that is EMPA, DAPA and canagliflozin are definitely useful. So percentage reduction in the composite of first event of cardiovascular death in patients with LVEF above 50%. If you look at the last two, the Paragon HF trial, which is also a ARNI trial compared with valsartan, shows a 6% reduction. So the reduction may not be robust, but it is still useful. Now, clinical facts about the heart failure with mid-range ejection fraction. Patients with heart failure with mid-range ejection fraction have multiple comorbidities, but the most important comorbidity is renal insufficiency and the similar incidence of coronary artery disease. Primary common cause of mid-range ejection fraction is coronary artery disease and has a high comorbidity burden with renal insufficiency in 26% of patients. The prevalence of heart failure with mid-range ejection fraction within the overall population of patients with heart failure is 10 to 25%. And why we should know this is, majority of patients who come to us years after the treatment for coronary artery disease, they may come for the first time for a routine checkup without much symptoms. And if you look at their echocardiogram, they may show an ejection fraction of 41 to 49%. Should we have to treat them with ARNI? The evidence is slowly evolving. Yes, they get benefited with exposure to ARNI. Now, phenotype risk of cause-specific outcomes suggest that CKD and IHD are prevalent in patients with mid-range ejection fraction. You can see the incidence of ischemic heart disease is slightly more in mid-range ejection fraction than in preserved ejection fraction. Similarly, chronic kidney disease is also more. Heart failure with the mid-range ejection fraction is a useful categorization of patients with heart failure and shares the most important clinical features of heart failure with reduced ejection fractions. Hence, it was suggested that the drugs that are effective in patients with HFrEF should also be effective in mid-range ejection fraction. And a substantial proportion of heart failure with mid-range ejection fraction patients resembling with reduced ejection fraction features have new ischemic events. So this is what we see. Patients come and get treated with us 10 years back for coronary artery disease. They have been on treatment regularly and majority of them irregularly. Many of them stop the treatment. They come back with new ischemic events and their ejection fraction drops down. And these are the candidates we have to be looking for in the management of F with mid-range ejection fraction. Evidence shows higher risk in mid-range ejection fraction patients in the presence of coronary artery disease. If you look at the FREF, the incidence is only 58% number of patients, ischemic etiology, and the F mid-range, it is 56%, whereas in preserved ejection fraction, the risk is very much less. Now, the data backing sacubitril valsartan or ARNI in mid-range ejection fraction. We have had several trials after the 2014 trial. 2014, the Paradigm HF recruited people with less than 40%. The later trials, Paraglide and Paragon HF trials, included patients with mid-range and above 50% ejection fraction. Above 50% if you take, the ARNI does not show very much of an improvement. But if you take patients with 41 to 49% in Paraglide and Paragon HF, they got definitely benefited by exposure to ARNI. 5.48% improvement in LVEF with sacubitril valsartan in heart failure with mid-range ejection fraction. See, what our patients ask is, when they come for an echocardiogram, sir, does it show an improvement? They are not worried about the quality of life. The quality of life definitely improves, and then only the quantification with the ejection fraction improves. And sacubitril valsartan offer better LV dimensions. Reduction in LV dimensions is much better when you expose the patient to the sacubitril valsartan. You can see the valsartan group having 5 centimeters, whereas this is only 4.7 centimeters. When the volume LV diastolic dimensions come down, naturally the ejection fraction is going to improve. Now, lowers rehospitalization rate. ARNI definitely lowers the rehospitalization in mid-range ejection fraction post-AMI. You can see the reduction in sacubitril valsartan group to 7%, and whereas the valsartan group had 18%. So what is important is the mortality reduction if it is agreeable. Why digoxin was thrown out? Because it does not cause mortality reduction. Whereas what are the drugs that have come to stay in are ARNI and later SGLT2 inhibitors, MRA and the beta blockers. Impact on clinical outcomes associated with renal dysfunction in patients with mid-range ejection fraction. We have already seen that patients with mid-range ejection fraction, they are more prone to have coronary artery disease and renal problem. You can look at the mortality in FREF and F mid-range. Both are very high compared to FPEF. So if you look at the renal dysfunction, sacubitril valsartan improves the eGFR in mid-range ejection fraction patients with CKD and coronary artery disease. Pre-treatment eGFR is 58 and post-treatment it has definitely improved to 66 ml. Sacubitril valsartan improves LVEF in mid-range ejection fractions, which we have already seen. That is why this talk definitely pre-treatment, this is GFR. Now, ACC guidelines recommends ARNI therapy in heart failure with mid-range ejection fraction and symptomatic heart failure with EF 41 to 49%. As usual, diuretic to unload the patient. Then SGLT2 inhibitor is class 2A recommendation. ACE inhibitor ARB ARNI 2B, MRA 2B and evidence-based beta blockers 2B. Even though beta blockers cause a phenomenal reduction of about 33%, MRA about 34%, ARNI about 20% reduction, still they are all in class 2B and SGLT2 is class 2A and diuretic in a patient with cardiac failure mid-range is about class 1 recommendation. Sacubitril valsartan may be considered for patients with mid-range ejection fraction to reduce risk of heart failure hospitalization and death. As usual, ARNI, beta blockers and MRA may be considered in patients with mid-range ejection fraction also. Now, sacubitril valsartan reduces NT-proBNP. One of the criterion is not only improvement in quality of life, improvement in ejection fraction, reduction in hospitalization for heart failure, and what is most important in the setting of acute setting is whether the NT-proBNP when you treat comes down or not. Definitely, meta-analysis has shown a reduction in NT-proBNP when you treat even patients with mid-range heart failure with ARNI. Improves the quality of life and reduces the risk of readmission and mortality rate in patients with mid-range ejection fraction. So, how does it work? You can see this is the quality of life in patients with heart failure with mid-range ejection fraction, and you are able to see that it is able to work in all the ranges of ejection fraction from below 20% and at least up to 45%. So, time to adopt guideline mediated treatment regardless of the ejection fraction, and this is the same slide. Over a range of ejection fraction, ARNI is helpful and useful. Paraglide HF trial, which I was mentioning, having a diverse population of ejection fraction more than 40%, stabilized after a recent episode of worsening heart failure. Patients on sacubitril valsartan saw a greater reduction in NT-proBNP than those on valsartan through 8 weeks. The latest terminology is, previously we had only acute chronic heart failure, chronic heart failure. Then came heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, heart failure with improved ejection fraction. The latest one is mid-range ejection fraction. And the more later one in 2023 is, what is the definition of worsening heart failure? Worsening heart failure is a condition in which the patient has been on treatment for coronary artery disease and cardiac failure. Suddenly he comes needing an increase in either the oral or intravenous dose of diuretics or stepping up of ARNI. If a person comes with these symptoms and the treatment is increase in diuretics either oral or IV or a stepping up of ARNI dosage, then he is called worsening heart failure. So, in all patients with worsening heart failure, the majority of them will have coronary artery disease associated, and majority of them would be in mid-range heart failure, and therefore all of them would require exhibition of ARNI in a higher dosage if they have been taking it already, or exhibition of ARNI if they are ARNI naive patients. So real world evidence also shows that statistically significant relative risk reduction in all-cause mortality compared with ACE inhibitor and ARB if you give them ARNI. So to summarize, it reduces the NT-proBNP, improves the cardiac structure and function, reduces the diastolic volume, reduces risk of mortality, reduces the risk of hospitalization, which is one of the main parameters that we look in all the cardiac failure drug trials, and reduces all-cause mortality. And therefore, as just to refresh ourselves, diuretics in class 1, SGLT2 in class 2A, whereas ARNI will come in class 2B for the treatment of management of patients with heart failure with mid-range ejection fraction. Thank you all.